Let's kick off this series with the basics. Every nurse, caregiver, and patient needs to know about what happens after a stroke, because recovery isn't a single event. It's a layered process that calls for clinical skill, emotional insight, and a whole lot of patience. First things first, which side of the brain was affected? The location of the stroke makes a big difference in how symptoms show up and how recovery unfolds. Here's a quick breakdown. Left hemispheric stroke, right-sided weakness or paralysis, right visual field deficits, aphasia, expressive, receptive, or global, slower, more cautious behavior, trouble with logic or calculations, more likely to have language difficulties. Right hemispheric stroke, left-sided weakness or paralysis, left visual field deficits, poor spatial perceptual ability, impulsivity and poor judgment, increased distractibility, often unaware of their deficits. In short, left-sided strokes affect language and logical processing. Right-sided strokes hit attention, awareness, and safety. Both bring real challenges, and the care plan has to match the deficits. Spasticity, the hand that won't let go. One of the more frustrating issues after a stroke is upper extremity spasticity. This isn't just stiffness, it's a hypertonic muscle response that affects function and comfort. Treatment options include botulinum toxin A, Botox, injections into wrist and finger muscles, can also be used in the lower extremities. Effects last 2 to 4 months. Stretching and splinting to help maintain range and prevent contractures. Oral medications like clofen or tizanidine when appropriate. Changing positions, no excuses. Turning every 2 hours is non-negotiable, even with a fancy pressure mattress. Skin breakdown and contractures are real risks. For side lying, place a pillow between the legs. Avoid acute flexion of the upper thigh to reduce the risk of edema. For prone positioning, 15 to 30 minutes a few times a day if tolerated, helps hyperextend hip joints, important for walking later. Prevents hip and knee contractures, aids secretion drainage, reduces pressure on the sacrum and ischial areas. Use a small pillow under the pelvis, from umbilicus to upper thighs for support. Yes, it feels awkward at first. No, that's not a reason to skip it. Exercise. Move it or lose it. Even if a limb is flaccid, especially if it is, passive range of motion exercises should be done 4 to 5 times a day. Goals: preserve joint movement, prevent contractures, promote circulation, reduce VTE risk. This is where the brain starts relearning. Each movement helps build new pathways. Repetition matters. Frequent short sessions are better than long, exhausting ones. Always watch for red flags: shortness of breath, chest pain, cyanosis, or rising heart rate. Stop if those show up. Otherwise, consistency is key. This first phase of recovery is about preserving function, preventing complications, and giving the brain and body the best shot at progress. Coming up in part 2, how to communicate with someone who has aphasia, and why your words, tone, and environment can either calm or completely overwhelm them. Until then, float the heels, reposition often, and don't underestimate the power of small gains. Recovery is slow, but every little step counts. Let's talk about something that hits hard for a lot of stroke survivors: communication. You don't fully realize how much we rely on language until it suddenly doesn't work the way it used to. Depending on where the stroke occurred, a person may develop aphasia, a language disorder that affects the ability to speak, understand, read, or write. It may be expressive, where they know what they want to say but can't get the words out. Receptive, where they hear words but can't make sense of them. Or global, which affects all areas of language. It's frustrating for the patient and for everyone around them. But there are real effective ways to help. Start where they are, not where they were. You're not trying to return them to who they were before the stroke right away. You're helping them navigate where they are now. Make eye contact and face them directly. They need to see your face, your mouth, your eyes, your calm expression. Approach from the front, not from the side. Let them focus on you without surprise or confusion. Speak slowly and clearly, not louder, not exaggerated. Just use your normal voice, short sentences, and give a pause between each thought. Let their brain catch up before you move on. Keep communication practical. Focus on daily needs: hunger, toileting, comfort, preferences. Examples: are you hungry? Do you need the bathroom? Would you like the window open? Keep it functional and concrete. Use gestures, objects, and visuals. Pair actions with words. If you hand them a spoon, say spoon. If they're brushing their hair, say brush. These associations help rebuild language pathways in the brain. Be consistent with your word choice. Pick one word and stick with it. If you say bathroom, don't switch to restroom or toilet later. The brain is relearning, and consistency reduces confusion. Minimize distractions. Turn off background noise. A TV, hallway conversations, or multiple people talking at once can overload a recovering brain. Keep the environment calm and quiet during communication. Now let's talk about the people providing care, whether you're a nurse, spouse, friend, or family member. If you feel awkward trying to connect, that's normal, but don't let that discomfort push you into silence or avoidance. And never talk about the person as if they aren't in the room. They're still there. Their mind may be sharp, even if the words can't come out. Important reminders. Don't finish their sentences unless they ask. Don't talk to them like they're a child. Don't assume they don't understand. Aphasia doesn't mean confusion or cognitive decline. Many stroke survivors with aphasia are fully aware and trying their best to reconnect with you. Every successful exchange, no matter how small, is progress. A nod, a smile of recognition. This is what rebuilding looks like. And your patience, your steady tone, your calm presence, your commitment to meeting them where they are, that's part of the healing process too. Let's talk about something that doesn't always get top billing during stroke recovery, but absolutely should: skin integrity. After a stroke, patients are at high risk for pressure injuries. Why? Because many of them have limited mobility, reduced sensation, and a slower response time to discomfort. If they can't move or tell you where it hurts, the skin suffers first. And once that skin breaks down, recovery just got a lot harder. First rule: turn every 2 hours. No exceptions. Even if the patient is on a high-end pressure-reducing mattress, you still need to reposition them every 2 hours. That's your baseline. What does turning actually mean? Change from back to side-lying positions. Use pillows to support alignment. Don't let them slide down or slump. This causes shear and friction. When they're side-lying, put a pillow between the knees. Keep the top leg slightly forward. Make sure the upper thigh isn't flexed too sharply, or you'll block venous return and cause swelling. And yes, if tolerated, try prone positioning for 15 to 30 minutes a few times a day. That's right, on the belly. It helps. Stretch hip joints. Drain bronchial secretions. Relieve pressure on the back and buttocks. Prevent contractures. Just be sure to use a small pillow under the pelvis, not under the chest or thighs, and always monitor closely. Hack skin checks. Not optional. At least once per shift, and ideally more, nurses should check all high-risk areas: heels, sacrum, elbows, scapulae, back of the head. Use a flashlight if the room is dark. Undress what needs to be undressed. Look at the skin. You're checking for redness that doesn't blanch, skin that feels boggy or warmer than surrounding tissue, any sign of moisture-related breakdown. Float the heels. Always. This one's easy to miss and critical to remember. The heels should never be resting flat on the bed. You can use pillows under the calves, heel suspension boots, folded blankets. Whatever works, just make sure the heels are floating. Keep it clean, dry, and moisturized. Stroke patients may be incontinent, sweaty, or unable to reposition themselves after toileting. That means skin can get wet and fast. Use barrier creams for moisture protection. Apply lotion to dry areas, but avoid putting cream in skin folds. Pat dry, don't rub. Keep sheets smooth and wrinkle-free. And yes, linen changes matter. A wrinkled sheet can cause more damage than you'd think. Special considerations for sensory deficits. Patients with decreased sensation may not feel pain or pressure, even if damage is happening. So don't rely on complaints. Rely on inspection. If they can't feel it, it's on us to catch it. One more thing. Skin is brain dependent. The skin doesn't act alone. It's controlled by the nervous system. So if the stroke affected motor or sensory pathways, it can also impact the body's ability to detect pressure, blood flow regulation, protective reflexes like repositioning. That means stroke patients are already behind the 8 ball when it comes to skin preservation, which means we need to be ahead of it. Bottom line, preventing pressure injuries is not about being perfect. It's about being proactive. Turn them. Float the heels. Check the skin. Keep it clean. Involve the whole care team. Document what you see and what you do about it, because no one ever says, "Thank goodness this patient developed a stage 3 ulcer." Let's talk about tools, because after a stroke, even the most basic tasks, brushing your teeth, getting dressed, sitting safely in the shower, can feel like trying to do brain surgery in mittens. That's where adaptive equipment comes in. These aren't just gadgets, they're extensions of independence, and the right tool in the right hands at the right time can mean the difference between needing help with everything and getting through the day with dignity intact. We're going to break it down by category so you know what to look for and when to use it. Bathing and grooming aids. Let's start with hygiene, because feeling clean is powerful. Grab bars and non-skid mats are a must in bathrooms. Falls are common, and wet tile isn't forgiving. A handheld shower head gives more control, especially if one arm is weak. Shower seats or tub benches, some are stationary, some roll in, offer safety without requiring balance. A long-handled bath sponge means less twisting and better reach. For shaving, electric razors with a 90-degree angled head help reduce awkward wrist motion and cuts. Dressing aids, next up, the daily puzzle of clothing. Elastic shoelaces make any shoe into a slip-on, no tying needed. A long-handled shoehorn saves your back and helps folks who can't bend or reach their feet. And let's hear it for Velcro closures on shoes, shirts, bras. Buttons and zippers can be a nightmare with poor hand coordination. Let's not make people wrestle their dignity back in the morning. These tools make it easier, faster, and safer to get dressed. Eating devices. Feeding yourself is one of the last things people want help with, so these are essential. Non-skid mats keep plates from sliding around. Plate guards create a raised edge so food doesn't end up on the floor or in your lap. Wide grip utensils are perfect for weak or shaky hands. Thicker handles mean better control. Simple, effective. No batteries required. Toileting aids. Now, we don't love talking about this part, but we need to. Grab bars next to the toilet help with getting up and down safely. A raised toilet seat reduces the distance someone has to lower themselves, which can mean the difference between independence and needing a lift every time. Toileting is about more than function. It's about dignity. These tools preserve both. Mobility aids. Mobility isn't one size fits all, but the right support can restore confidence and freedom. Canes and walkers help with balance and gait retraining. Wheelchairs may be temporary or long-term, depending on deficits. Transfer devices, like transfer boards or gait belts, make it safer for caregivers to assist with getting in and out of bed, chairs, or cars. And please, if someone's transferring alone, they still need the right technique and possibly a physical therapy consult. Why all this matters? This isn't about stuff. It's about letting people participate in their own lives again. Stroke recovery is tough enough. If a device helps someone brush their hair without help or eat their own lunch, that's not a small win. That's power. That's identity. That's healing. And here's the thing. What works today might not work next month. Patients change. Strength improves. Sometimes it regresses. So the care team needs to reassess regularly. Keep an eye on what's working, what's gathering dust, and what could be swapped out for something better. Bottom line, every adaptive device is a chance to reclaim a little more of what was lost. Use them, teach others how to use them, and don't ever let anyone tell a stroke survivor that their independence isn't worth fighting for. Let's talk about something that doesn't show up on a CT scan, but hits just as hard, the emotional toll of a stroke. And not just for the patient, for the whole family. Recovery isn't only about muscle strength or speech therapy. It's about adjusting to a new reality no one asked for, and that takes time, grace, and support. When someone has a stroke, they're not the only one who changes. Their spouse, their children, their friends, everyone around them feels the shift, especially when that stroke takes away not just mobility or speech, but the roles and routines that defined a person's life. Maybe they were the caregiver. Maybe they paid the bills or ran the household. Now those responsibilities fall to someone else, often with little warning and even less training. Let's start with the patient. A person recovering from a stroke might look fine from across the room, but inside, they're grieving the loss of independence, grieving their former self. That can show up as frustration, irritability, or even apathy. And for about 1 in 3, it turns into post-stroke depression. This depression often goes undetected, especially with shorter hospital stays or when physical needs take center stage. But nurses and caregivers should be watching closely for red flags. Flat affect, tearfulness, withdrawal, or when a patient stops engaging in therapy or conversation altogether. And it's not just about the patient's mood, it's about outcomes. Depression can delay rehab progress, increase readmissions, and even impact survival. So we don't just brush it off. We screen for it, we name it, and we get help involved early, whether that's counseling, medication, or peer support groups. Now let's talk about caregivers. This part's personal, because the minute someone you love has a stroke, you're in it, ready or not. A spouse may suddenly become the driver, the medication manager, the hygiene assistant, the emotional support person, all while dealing with their own health problems or job stress. Many are dealing with a loss of the relationship they once knew. They may feel guilty for being tired. They may be overwhelmed but don't want to complain. Some push through for weeks, even months, without a break, until they burn out. Globally, up to 40% of stroke caregivers develop depression. That's not just a statistic. That's your patient's daughter. That's the husband who doesn't say much but hasn't left her side in 3 days. That's the mother who's sleeping in a chair at the foot of the bed. As nurses, it's our job to recognize the strain. We don't just ask how the patient's doing, we ask how the caregiver's doing. We offer resources. We remind them they're allowed to rest. That respite care isn't weakness, it's survival. Adult day programs, weekend hospital respite, even just someone to sit with the patient for a few hours so they can shower and go to the grocery store alone, it all matters. We also need to help set expectations. Stroke recovery isn't linear. There will be setbacks, there will be plateaus, but there will also be wins. Small ones at first. A smile, a word, a finger that moves. We teach families to look for those, to celebrate them, to keep hope alive even on the hard days. And through it all, we remind them, you don't have to be perfect. You just have to show up, ask for help when you need it, and love them the best way you can. So what's our role as clinicians in all this? We normalize the grief. We educate without overwhelming. We refer to mental health when it's needed. And we make sure the caregiver's name is in the plan of care, because they're a patient too in all of this. Let's talk about something nobody puts on the discharge paperwork, but it's still a big part of recovery: sex after stroke. Now, I know it can feel awkward. Patients are nervous. Families avoid the topic. Even clinicians hesitate, like they're not sure it's allowed. But here's the truth. Sexual health is part of being human, and stroke survivors don't stop being human when they leave the hospital. Sexual function changes after a stroke. Not for everyone, but often enough that we need to talk about it. Because when we don't, patients end up feeling ashamed, confused, or alone in something that's actually very common. First, the physical side. Stroke can change how a person moves, feels, or thinks. Maybe their balance is off. Maybe one side of their body doesn't respond the way it used to. Or maybe they're just tired all the time, physically and emotionally drained. Muscle weakness, spasticity, even things like drooling or urinary incontinence can chip away at someone's confidence. They may feel like they're no longer attractive, or like their body betrayed them. Then you add in medications, antidepressants, blood pressure pills, seizure meds, and now we're talking about real changes in libido or sexual performance. For men, erectile dysfunction is common. For women, lubrication may be reduced. And for everyone, desire can take a hit. Now let's talk about what's going on emotionally. After a stroke, people grieve. Not just their mobility or speech, but their identity. Maybe they were the strong one, the caretaker, the person who planned the vacations, paid the bills, or fixed the car. Now, they're the one being helped to the bathroom. That shift can make someone feel small, or invisible, or like they're no longer a partner in the relationship, just a burden. And for the partner, that's complicated too. You want to help. You want to be kind. But you're tired, you're scared, you're grieving too. And somewhere along the line, you've become the caregiver instead of the lover. So what do? We talk about it, with care, with openness, without awkward pauses or judgment. If you're the nurse, you can say, open quote, "Many people have questions about sex after stroke. Would you like to talk about that?" Close quote. That one sentence can open the door. If they say no, fine. But if they say yes, you've just given them permission to reclaim a part of their life they thought was lost. What else can we offer? Education. That sex is safe for most people after a stroke, unless the doctor says otherwise. Positioning tips. An occupational therapist can help. Emotional support, referrals to counseling, peer support groups, or therapists who specialize in chronic illness and intimacy. And most importantly, we validate the loss without acting like it's the end of the story. Intimacy doesn't have to mean intercourse. It can mean touch. It can mean time together. It can mean laying in bed, laughing at a movie, or holding hands during rehab. Here's what we teach families and partners. Be patient with each other. Talk about what's working and what's not. Redefine what closeness looks like for now, not forever, just for right now. Give yourselves permission to adapt. That's not giving up, that's growing together. Sexual health isn't a bonus. It's not selfish. It's part of recovery, and it deserves just as much time and attention as blood pressure or mobility. So the next time a patient or partner hesitates, remind them gently, open quote, "You're allowed to want connection. You're allowed to feel attractive. And yes, you're allowed to ask for help figuring out how to get there." Close quote.